Uh, okay. Today we'll have a discussion on two hernias, which are not very common, uncommon hernias, but these are often in the exam. Lumbar hernia, you rarely get case to be put in the exam, but that may be for discussion. But femoral you can get. So Dr. Komal Sharma is a third-year resident at IPGM SSK Hospital to present the cases. Komal, you can please start the first case and present.
Yes, sir. Good morning to everyone present. I am Dr. Komal Sharma from IPGM here, and I shall be presenting two cases. The first case, is that of a 47-year-old female patient residing in Kolkata, presenting to the emergency department on 11th of May 2022 at around 5 p.m. Her chief complaints included swelling in the left groin since past 1 year, pain over the swelling since 3 days, and inability to pass stool and platters since 3 days. The left groin swelling was present since 1 year. It was insidious in onset, increased on size, on coughing and straining, and reduced slightly on rest. However, it never reduced completely. It was associated with mild intermittent pain initially, but since the past 4 days, there was a continuous dull ache in the region. It was not associated with any skin changes, fever, loss of body weight, or any other swelling in the body. The pain was situated in the left groin, was sudden in onset 3 days ago, rapidly increasing, colicky in character, non-radiating, associated with loss of appetite, associated with inability to pass stool or flatus, along with a feeling of fullness in the abdomen. The patient suffered from chronic constipation since the past several years. There is no history of any major illness or any other surgery in the past. The patient was postmenopausal, had 4 normal vaginal deliveries, was non-alcoholic, non-smoker, and a standard non-vegetarian diet. She was non-diabetic, non-hypertensive, and no chronic diseases were known for which she was on any medication. There was no history of any similar illness in her family. The general physical examination showed that the patient was alert, conscious, and cooperative, of a moderate build. No evidence of pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. The tongue was dry. Her BP was 98/66. She was tachycardic with a pulse rate of 102 beats per minute. The respiratory rate was 18 breaths per minute. The SpO2 was 99%, and she was aphid. Systemic examination showed normal overall assessment. Abdominal examination, on inspection, the abdomen was protuberant in shape and slightly distended. The umbilicus was inverted and centrally located. All quadrants were moving equally with respiration. There was no visible pulsation or peristalsis, and there was a swelling present in the left groin. On palpation of the abdomen, there was no local rise in temperature, no tenderness, no organomegaly. Percussion revealed a tympanic sound. No fluid thrill or shifting dullness was present. Vowel sounds were absent. Local examination of the swelling was done in standing position first. It showed a single swelling located over the left groin, just below the groin crease, globular in shape, around 3 by 3 centimeter in dimension. No cough impulse was present, no pulsation, and no visible peristalsis was present. Skin over the swelling was normal. In supine position, there was no alteration of shape or size of the swelling. On palpation, it was present below and lateral to the pubic tubercle. There was no local rise of temperature over the swelling. There was some tenderness present. The swelling had a smooth surface, well-defined margins, firm consistency. It was non-fluctuant, showed no fluid thick, was non-compressible, irreducible, and not fixed to the overlying skin. On percussion, there was a dull note over the swelling, and on auscultation, no vowel sounds were heard. We performed a digital X-ray of the abdomen in an erect posture.
We'll discuss.
Yes,
we'll discuss. Go back to the first slide of presentation.
Yes, sir. Yes, sir.
Yeah. So this is a 47 years lady presenting to emergency.
Yes,
Okay.
sir.
So these are the three chief complaints. Go to the history of present illness. So in history of present illness, you try to understand that she has got a swelling in the region of groin near the uh, uh, possible sites of hernia. So here you should describe the swelling. You have described the swelling properly. Next slide. Describe the pain. Next. Then you passed on to the past history to understand. So patient with hernias, when you suspect it might be a hernia, you should think of the whole inguinoscrotal region. Okay, in a female, it's a vulval region. So here you should also ask in the swelling whether patient has got any other swelling in the groin on the same side, or she has got any swelling in the opposite inguinovulval region. Okay, that should come. Second is, in same history of present illness, you have to describe whether she has got some symptoms pertaining to that will not go to past history because she has constipation. It is still having constipation. So in the history of present illness, like in any groin hernia you describe, you should describe her chest symptoms, whether she has got chronic cough, whether she has breathlessness. You describe the urinary habits, whether she is passing normal bowel and bladder habits, any staining during maturation. Okay, so this chronic staining factor has to be described in history of present illness. Then comes a personal history and family history. Okay, why do you try to mention that no history of similar illness in the family? Is there a genetic basis of this disease?
No, sir, but there might be predisposing factors like any connective tissue disorders that might
Yes.
predispose to hernia, sir.
Yeah. So it's although very rare, but some patient may have collagen disorder which can run in families, and there may be some instance of hernia in the family tree. Okay. Next. Next. Yeah. When you go for a patient of hernia presentation, you can take the general physical examination and then don't start describing the system examination in details before you go to this. And then come to the local examination. Yes. You see, try to understand. This is not a local examination of the swelling itself. What we are doing is she has got a swelling in the region of the groin. So it will be an examination of the whole inguinoscrotal region. Think of a patient of inguinal hernia presenting. You examine the local examination in the area of the examination of the inguinoscrotal region. So patient is standing and you comment about the inguinoscrotal region. Left inguinovulval region is normal. On the right side, you said there is a swelling on the, in the left side, sorry. Right side is normal, and on the left side, you find there is a swelling in the groin, and you describe the swelling. Then you, next, as you go to the palpation, the first thing you have settled is what is this line depicts that swelling is lying lateral to the pubic tubercle.
Sir,
What
it
is
is
the
a differentiating point from inguinal hernia, sir. It could be above the pubic tubercle in case of an
above and
hernia.
medial?
Above
Above and medial will be a inguinal hernia, and below and lateral will be
femoral hernia, sir.
femoral hernia. Okay, and then you have, once you have commented that tenderness is present in patient who is presenting with pain, who is presenting with vomiting, you suspect that this patient has got a either obstructed or strangulated hernia. Okay, so these two are just progression of one condition to the next. If you say some tenderness is present, I will suspect this patient might have a obstructed hernia. Okay, but a patient who has got a rebound tenderness, it can be then easily made out clinically that she has got a strangulated femoral hernia. You have not given the diagnosis. Investigation, before investigation, the diagnosis will come. You have to summarize and give a diagnosis. Okay, so you describe the swelling, and patient who has got such a swelling, the swelling is 3 centimeter. It is very difficult to appreciate the percussion note over such a swelling. So in that case, you can skip. You can say that, sir, I cannot appreciate the percussion note because swelling is about just 3 centimeters. You think of your finger. It's small 3 centimeter swelling. It is difficult to appreciate the percussion note. Some examiner does not like that you percuss a hernial swelling to say it is resonant or not. Okay. Next. Next. Then it's not investigation. Next, you should be telling us the summary of the case. Come, might be summaries there.
Yes, sir.
Yeah. So you should give a summary. Just summarize this patient.
47-year-old female patient presenting with an irreducible swelling over the left groin, along with abdominal pain, distension, inability to pass stool and flatus for three days. On examination, having some dehydration, tachycardia, but normal systemic examination, and 3 by 3 centimeter swelling in the left groin, which was tender to touch, which was irreducible, tender to touch, and
you should say the same go. Swelling is mildly tender, but there is no rebound tenderness. So that is one of the important clinical parameter to say this is a obstructed and not a strangulated hernia, because this is a very close diagnosis. A obstructed hernia will go by 3 days time, and obstructed hernia will probably go to strangulated hernia. Okay. So you put some differential diagnosis. Okay.
Yes, sir. The differential diagnosis in this case included left inguinal hernia.
Why do you keep a diagnosis of left inguinal hernia in this patient? You see, sometimes femoral hernias, as the hernia grows, the hernia can emerge in the thigh. Can it go above the inguinal ligament? Can the femoral hernia go above the inguinal ligament?
So usually it does not go above the inguinal ligament.
But sometimes it can go once the through which opening the femoral hernia can come to the thigh. First is come to the femoral canal, and then it exit through. If you take the femoral canal, why does the femoral canal end below?
Sir, near the cribriform mark.
The cribriform is in the femoral opening ring. As you trace the femoral canal, it ends the saphenous opening. Okay. So once the hernia descends and come to the saphenous opening, it can now go upward towards the inguinal ligament. So if the hernia is confined only below the inguinal ligament, it is below and lateral to the pubic tubercle, it is not necessary that you keep a DD of inguinal hernia. If the hernia has emerged through this and then gone above the inguinal ligament, then you keep the posterior inguinal hernia. Otherwise, it's not necessary. Then, if you have a clear history, that the swelling was reducible earlier for last 1 or 2 years and then become irreducible, then now it is irreducible. Now a DD of irreducible swelling comes. In that case, a inguinal enlarged inguinal lymph node, a lipoma, or a femoral artery aneurysm or pseudaneurysm can come. But if the hernia is reducible, then it is not wise to keep the possibility of this. If the hernia is reduced, here is being non-reducible, you can put some DD. Otherwise, hernia that is reducible, it is not necessary that you keep a DD of other things. Okay, so you said it's obstructed left-sided femoral hernia. What are the points in favor of your diagnosis?
So the swelling is, which was earlier reducible, has now become irreducible for the past 3 days. It is associated with inability to pass stool and flatus, along with abdominal distension and some vomiting. So
these are the features of obstruction. These are the features of obstruction.
Yes.
Okay. I asked simple, why it is femoral hernia?
Sir, the swelling is, firstly, sir, female patient. Females are more predisposed than males to femoral hernia.
So it's a female patient and elderly female patient.
Yes, sir.
Then
and a multipara, sir. She has
Yeah.
had 4 normal vaginal deliveries, so leading
Yes.
to the laxity of the femoral canal.
Okay.
Then, sir, on examination, sir, the swelling was
History, what
present
she said. History, she gave you some lead. She noticed the swelling where? In the groin,
in
in
the
the above
groin,
lingual
sir.
ligament or below?
Sir, she could not say where she first noticed the swelling, but she pointed to the region below the groin crease, sir.
Okay. So she complained of a swelling below the groin crease.
Yes.
And she said initially, what was the nature of the swelling?
Initially, it was reducible, sir, and not
So that is
associated
very
with any
important
pain.
point in history. On history, that is a very important point for a diagnosis of femoral hernia. She complained of a swelling in the groin crease below the region of inguinal ligament, and then the swelling was initially reducible, and for last 3 days become irreducible. And on examination, you find a swelling where to justify his femoral hernia?
Sir, it was below and lateral to the pubic tubercle, sir.
Yes, it was below. That is a point similar to femoral hernia. And you said obstructed left side hernia. Why it is now a situation of obstruction?
So, because signs and symptoms of intestinal obstruction are present,
Yes.
including
And
abdominal distension and
yeah,
vomiting, inability to pass stool and flatus, pain in the colicky pain in the abdomen with dilating pain over the swelling, and on straight X-ray of the abdomen, sir, there was
no
multiple air
X-rays. No,
fluid.
I'm not going to the X-ray. I'm keeping to the clinical part.
Okay,
Okay. So this patient has got a swelling which become irreducible. She is having pain. She is having other features of intestinal obstruction like abdominal distension, vomiting. And on examination, you find the hernia is irreducible. It was tender, and uh, uh, if you examine the abdomen, you can have a situation of abdominal distension, or patient may have increased peristaltic sounds in the abdomen. Okay, so these are the points in for diagnosis of obstructed left inguinal hernia. So, what is the average incidence of groin hernia in male and female patients? I mean, groin hernias, not I'm talking of femoral or inguinal. What is the average incidence of groin hernias in man and woman?
sir, groin hernias are more common in male patients, sir.
Yes,
Uh,
and the incidence is about 25 to 40% of male patients in the lifetime may have hernias, and the incidence in female is much less, 3 to 6%. Out of these groin hernias, what percentage of patient may have femoral hernias?
sir, in female patients, sir, around 10% may have femoral hernias.
If you take the overall incidence, it is about 3 to 6%. It's a rare
Yes,
hernias, and in this, the femoral hernia is more common in females. Why?
yes, sir.
Why femoral
Sir,
hernia
because
is
of
more?
a wider femoral canal and sir, laxity of the femoral ring because of multiple pregnancies, sir.
Okay. When you talk of the femoral hernias, there are some subtypes of femoral hernias. What is Logier's hernia?
I don't know, sir.
So this femoral hernias, this usual described femoral hernia is coming to the femoral ring. Some hernias may come through the lacunar ligament. Through the lacunar ligament is a broad sheet of tissue. If the hernia descends through the lacunar ligament, it is described as Logier's hernia. There is another variety known as Nerath hernia. What is that? Nerath hernia. This is a variety of hernia where the hernial sac descends behind the femoral vessels. This happens in patient who has got an associated congenital dislocation of hip. Okay.
Okay, sir.
What is cloquet hernia?
Sir, when the hernial sac descends through the lateral most compartment, sir.
Lateralmost? No, lateralmost compartment is of the femoral sheath is the artery. The cloquet hernia
Sir,
is
along with the
described
lead.
as when the hernia descends behind the fascia pectineus. Pectineus is attached to the pubic ramus. When the hernia descends behind the pectineal fascia, it is described as cloquet. These are all very rare hernias, but there are some subtypes of femoral hernia being described. Okay.
Yes,
So, what type of obstruction occurs in femoral hernia more commonly? is it an obstruction same as a inguinal hernia, or this obstruction is of some other varieties? When the hernia descends in the femoral ring, is it that whole loop goes in and the obstruction is of a closed loop obstruction, or it is something different?
Sir, since the opening of the femoral canal is much smaller than that of
Yes.
the
So what happens?
inguinal ring,
What
sir,
that
only a
particular type
segment
of
of
hernia
the
is described as? What that
sir,
particular type of described as? If you have a circumference of bowel coming to the femoral canal through the femoral ring and that get obstructed, what is that type of hernia described as? That is, what is Richter's hernia?
yes, sir. When one segment of the bowel is
Yeah,
involved in the hernial sir.
and segment means a part of the circumference of the bowel is entering into the femoral canal, and because of the narrow neck, this may become obstructed, and then it can proceed to strangulation. Okay, so this is a patient having femoral hernia, uh, and she is arriving in emergency. Do you need an investigation to confirm the diagnosis of hernia in this patient?
No, sir. Sir, it's a clinical diagnosis, sir.
Yes.
Since sir, she gives a typical history of an obstructed hernia, and sir, on clinical examination, sir, we can delineate it as a femoral hernia. Sir, if investigations are not possible, sir, we can proceed directly for the management of the patient.
Yes, but sometimes what happens is, how does a femoral hernia patient usually presents?
Sir,
Usual
usually,
presentation.
sir, usually it is a reducible hernia, although the presentation or acute presentation is more common compared to femoral,
Yes,
compared to
and
inguinal hernia.
there are a group of patient who may be asymptomatic,
Yes, sir.
particularly patient who are obese. Obese patient may not notice the swelling. There may be simple a groin pain. You
Yes,
understand?
yes,
Some
sir.
patient may present only the groin pain, no swelling. So in that case, in obese patient, it is not possible to clinically diagnose that patient has got a femoral hernia. You cannot appreciate the swelling. Okay,
Yes,
and
sir.
this patient is a different group of patient who clearly mentioned that she has got a swelling in the groin, and that swelling was reducing, and now the swelling become irreducible. So history wise, this patient has got a good diagnosis of hernia. But if you have a doubt, if you have a doubt that there is a swelling in the groin and the swelling is likely to be hernia or maybe something else, then what should be your line of investigation?
Sir, a USG of the inguinoscrotal or inguinolabial region,
Yes.
sir.
Yes. EOG is a good investigation to give a diagnosis. Okay. But again, in very obese patient, USG may not be reliable. In that case, what can be the next
Sir,
investigation?
CT, sir,
Yeah.
CT scan.
Yes. It should be a CT scan. You can find out whether the gut is there or not. Okay. If you suspect strangulation, you can make out whether this area of the gut is not vascularized. Okay.
Yes.
How will you treat this patient?
Sir, since this is a acute presentation, sir, operative intervention after appropriate resuscitation will be required. Sir, in this case, we approached sir via transinguinal incision, and sir, the hernial sac was identified, and sir, the
The
sac was
answer
opened.
should be, you already said the patient is in shock.
Yes, sir.
She has low BP, she has tachycardia. So the management in this situation would be resuscitation of the patient,
Yes, sir.
followed by some baseline investigation to assess her fitness, and then proceed for that should be the reasonable answer.
Okay.
This patient is emergency arrival with features of shock. So this patient needs immediate resuscitation, and then I will do some baseline investigations, and then I will consider doing the surgical part of the management.
Yes, sir.
And what surgery you plan for this patient?
Sir, in this patient, sir, sir, Lockwood incision, sir, Lockwood approach was made.
What is that?
Uh,
A
sir,
Lockwood approach is what?
sir, transinguinal approach, sir, where the where the incision was made, sir, parallel to the inguinal ligament, just extending from the pubic tubercle to the deep inguinal ring. The transversalis fascia was accessed through that incision. Also, the hernial sac was identified, and sir, there was reduction of the hernial sac followed by a repair of the femoral ring via mesh plug repair. The gut content was found to be healthy, sir. So
No,
no
wait,
resection MS control.
wait. Once you have a suspicion of obstructed or a strangulated hernia, suppose you have a suspicion of strangulated hernia.
Yes, sir.
Okay. So where will you open the hernial sac? If you have a suspicion of a strangulated hernia, at which point you will open the hernial sac first and why? What happens in
Sir,
strangulated hernia?
sir, there is accumulation of toxic fluid in the hernial sac.
Yes. So
So,
there is
sir,
a
the
toxic.
hernial sac was opened out, sir, before reducing the hernia, sir.
Yes. Where?
And the toxic fluid was,
Where will you open? Will you divide
sir,
the
at the
neck first? Fundus.
fundus,
Yes.
sir.
So the idea is once you raise the skin flap, as you incise the external aponeurosis, you are in the inguinal canal, and this is basically a direct hernia taking exit to the femoral ring.
Yes.
So you descend the hernial sac, open the fundus, drain the toxic fluid. If it is just simply obstructed and there is a tight ring around, you cannot reduce the hernia. What step will take? Is a very tight
Sir,
ring. You cannot
sir,
reduce the hernia. What step will take to manage the situation?
sir, to release the constriction ring, sir, we
How?
can give an anterior and an incision anteriorly, sir.
Entry means where?
Sir, either we can give over the inguinal ligament or over the lacunar ligament. Sir,
No, it's
lacunar
not.
ligament
Usually,
is
it is
not
not
preferred.
inguinal ligament. Usually, it is not. You are not dividing the inguinal ligament.
Yes, sir.
Once the neck is there, the neck is tight. It is difficult to incise the inguinal ligament. You can injure the gut.
Yes, sir.
The described technique is to divide the lacunar ligament.
Lacunar ligament, sir.
Okay. What
Yes,
precaution you should take while you divide the lacunar ligament?
sir, there might be an aberrant obturator artery
Yes.
in the
So
region,
if
sir.
you
So we should
while
take
dividing, you
precautions, sir.
should take care whether there is an abnormal obturator artery, because once you divide and you injure the abnormal artery, there will be torrential bleed, which is
Yes,
difficult to control. Okay. So if
yes,
the
sir.
hernial ring is very tight, narrow, you need to divide the lacunar ligament. So hernial sac is tackled by transferring the neck. How will you do the next part of the repair? If it is obstructed hernia, can you put a mesh?
Sir, if there is no contamination or no toxic fluid, sir.
Obstructed, yes. Oh, why not? Obstructed
Yes,
hernia,
sir.
once you relieve the obstruction, you can put a mesh.
Yes, sir.
It is in strangulated hernia, when you need to resect the segment of the gut, that is a situation that mesh placement is not advisable.
Yes, sir.
Okay. In obstructed hernia, you can place a mesh. So if you are tackling the patient of hernia, which is femoral, how it differs from the standard Liechtenstein operation?
Sir, sir, in this, sir, usually, sir, we use a mesh plug, sir, instead of a flat mesh. Sir, by rolling.
My point is how the operation for femoral hernia with a mesh differs from operation of a standard Liechtenstein operation for a groin inguinal hernia.
Sir, a tension-free apposition of the sir hernial opening.
Which opening?
Sir, the femoral hernia opening, sir.
How
Sir,
do you
the
close
repair
it?
is hardly tension-free, sir.
How do you close the femoral ring? There is a large femoral ring because of the
Yes, sir.
hernia.
Yes,
So
sir.
this is a gap between which ligaments?
Sir, between inguinal ligament and Cooper ligament, sir.
Yes. So how do you obliterate this gap?
Sir, using a mesh plug, sir.
No. If you can use a standard mesh, if you use only mesh plug, you are not taking care of the groin.
Yes,
So
sir.
this gap can be opposed by 2 or 3 interrupted sutures between the inguinal ligament and the Cooper's ligament.
Yes, sir.
Clear? So this femoral hernial ring is closed by one or two or three interval switches by inguinal ligament to this Cooper's ligament. And now you are going to place the mesh. Where do you place the mesh? Where do you fix it?
So it is placed in the inguinal canal,
Uh,
medially, sir, and it is fixed to 3 points, sir. Anteriorly, it is fixed to the inguinal ligament, posteriorly to the Cooper's ligament, and medially to the lacunar ligament.
don't get confused. Try to understand. Once you are dealing with the femoral hernias, you have exposed the Cooper's ligament.
Yes, sir.
So once you place the mesh in femoral hernia repair, your mesh below is to be fixed to the Cooper's ligament.
Yes, sir.
And where does the Cooper ligament ends? Where does the Cooper ligament ends? You got my point? Anatomy. Cooper ligament starts in the pubic tubercle and goes along the superior pubic ramus.
Yes, sir.
Where does it end? It ends at the femoral sheath.
Yes, sir.
Okay. In the femoral sheath, it gets blended. So as you trace the Cooper's ligament, lateral to the femoral ring align the femoral vessels. And Cooper
Yes,
ligament ends there. There is no Cooper's ligament lateral to the femoral vessels. So as you place the mesh, you fix the mesh, lower part of the mesh to the Cooper's ligament. And as you come laterally, you fix the mesh to the
femoral sheath.
not femoral sheath. You fix the mesh to the inguinal ligament.
Okay, sir.
You got my point. As
Yes,
you
sir.
come medially the mesh is fixed to the Cooper's ligament. Laterally the mesh is fixed to the inguinal ligament. And
Okay, sir.
medially the mesh is fixed to the rectus sheath. Above the mesh is fixed to above, same as inguinal hernia.
Sir,
Where do you fix?
to the sir transversalis.
Conjunct tendon.
Yes, sir.
Superiorly you fix the mesh to conjunct tendon, and
Yes, sir.
laterally, if it is round ligament, you can divide the round ligament or make a split and accommodate the round ligament, or in male it's a somatic cord. Okay, that is the difference. Here you cannot fix the mesh to the inguinal ligament medially, because then you are ignoring the gap in the uh, femoral ring. Okay, that is the difference in technique. What are the complications of this femoral hernia repair?
Sir, if sir the closure is too tight, then there might be compression of the femoral vein, sir. So leading to lower limb edema. There might be intraoperatively, sir. There might be vascular injury to the femoral vessels or to the aberrant artery, sir. There
That
might
means
be
bleeding.
recurrence.
You mean bleeding?
Yes, sir. So,
Bleeding.
sir,
Then
there might be mesh infection.
seroma, seroma.
Seroma, sir, meshoma, need for mesh infection,
Yeah.
hematoma, sir, chronic groin pain syndromes may be present, sir, and lymphedema of the leg, sir, edema of the leg due to femoral vein compression may occur, sir.
Okay. Okay. Fine. So for a femoral hernia, you should give a clear presentation. Keep in mind the local anatomy of the femoral sheath, the femoral ring, and the femoral canal, the saphenous opening. What is the normal content of the femoral canal? What is the normal content of the femoral canal?
Sir, usually, sir, some lymph nodes might be present.
There is a fixed lymph node there.
Sir, clockets.
Yes. In the femoral canal, the clocked node is a constant,
Yes, sir.
and also contains some loose cellular tissue and the lymphatics. But clocked
Yes.
node lies in the femoral canal
Yes, sir.
near the femoral ring. Okay.
Yes.
Okay. Thank you. We can pass on to the lumbar hernia presentation.
Yes. So the second case was of a 38-year-old male patient, resident of Shiliguri, shopkeeper by profession, presented to the outpatient department on 29 September 2021, with chief complaint of swelling in the right loin since one year. He was apparently well 1 year ago when he noticed a swelling in the right loin, which was insidious in onset, gradually increasing in size, painless, increased in size on straining, particularly and partially reduced in size after rest, which was not associated with any skin changes, ulceration, change in bowel or bladder habits. The patient had a normal sleep and appetite. He was a known smoker and had no other addictions. There was no history of chronic cough, constipation, urinary symptoms, no chronic disorders, and not on any medication at present. He did not have any past history of surgery, major illness, or trauma. The patient was married with 3 children, and there was no history of similar disease in the family. The general physical examination showed that the patient was alert, conscious, cooperative, moderately obese, and had a BMI of around 28 and no evidence of pallor, icterus, cyanosis, clubbing, edema, lymphadenopathy. The vitals were stable and systemic examination was within normal limits. Abdominal examination, the abdomen was protuberant in shape, umbilicus was inverted and centrally located. All quadrants were moving equally with respiration. No visible pulsation or peristalsis, and a bulge was noted in the right loin. Palpation of the abdomen showed no local rise of temperature, no tenderness, and no organomegaly. And there was no fluid thrill or shifting dullness in the abdomen, and bowel sounds were present 4 per minute. The swelling in standing, the examination of the loin region in the standing position showed a single swelling located over the right loin, globular and ill-defined, around 6 by 6 centimeter. The coughing pulse was visible, and swelling became more prominent on doing Valsalva maneuver. There was no pulsation or peristalsis visible, and skin over the swelling was normal. In supine position, there was a slight decrease in size of the swelling. On palpation, there was no local rise of temperature and no tenderness over the swelling. The swelling had a smooth surface, ill-defined margin, soft consistency. It was reducible, non-fluctuant, no fluid thrill was present, and it was not fixed to the overlying skin. It was dull on percussion, and no vowel sounds were heard on auscultation in the swelling.
Okay. Again, history part you should rectify. Okay, come to the history. Yeah. History of next. You see, history is not only of the swelling itself. Kamal, try to understand that you are describing a patient having a swelling in the loin, and then associated with this history of swelling, some other points come in favor of your diagnosis, or to say that the swelling is reducible, whether he's got any chronic staining factors, which can be factors for the hernia formation, or can bearing on the treatment also. Okay. Next. Yeah, you see, if this personal history is having some points, but in a patient who got a hernia, we need to describe the bladder and bowel with little more details to understand whether the patient has got any chronic staining factors. Okay.
Yes.
Next. Yeah. So again, a general physical examination followed by, this is a swelling in the, you see, you have shown the picture, it was almost occupying the whole of the lumbar region. So if you take the simple general physical of the abdomen, this hernia will be covered. You need to make a separate examination, local examination for the swelling. This is swelling which started in the loin and then has involved a large area of the body. It's almost a 10-12 centimeter swelling. So here the heading will be examination of the abdomen itself. And if you describe the abdomen, you describe the front, and as you go to the loin, the region of the renal angle area, you can appreciate that the swelling is coming from that region.
Yes, sir.
Okay, what's your diagnosis?
Sir, in this patient, the diagnosis is that of a reducible lumbar hernia, sir.
What lumbar hernia? Once you say it's a case of reducible lumbar hernia, you have to specify whether this hernia is through the superior lumbar triangle or inferior lumbar triangle.
Sir, superior lumbar hernia, sir.
Okay, so it's a hernia, Greenfield hernia or Lesseps hernia. So this is a hernia to the superior lumbar triangle of petit without any complications at present. That is the diagnosis.
Yes, sir.
And it's a primary or it's a secondary to trauma or some operations.
Sir, primary hernia.
It's a primary hernia.
Yes.
And this hernia, if the hernia is reducible, you have to try to appreciate the gap, because each classification now has a specification of this ventral hernias. So this is one of the primary ventral hernia where you can write as per each classification, giving the gap. How is the gap assessed in patient like this?
Sir, after fully reducing the hernia, sir, we try to palpate the abdominal wall for the gap, and sir, we can
Ask the patient to make the muscle taut. Ask the patient to make the muscle taut.
Yes, sir.
Okay, and then you can appreciate the gap. And what is W1, W2, W3 in EHS classification for primary ventral hernia?
Sir, sir, in EHS classification, the W stands for the width of the hernial gap, sir.
What is W1?
Sir, sir, from 0 to 2 centimeters, sir.
Yeah, 0 is no hernia, so it is
Yes, sir.
less
Up to
than
2 centimeters, sir.
Yeah. And
sir, sir, W2 is sir, W2 is from 2 to 5 centimeter, 3 to 5 centimeters, sir.
no, 2
And
to 4,
more
2
than
to 4, not 5.
4 centimeters. Okay, sir. And
Up
W3 is
to
more
2
than 4
is
centimeters.
up to 2 is W1. More than 2 to 4 is W2, and more than 4 is
W3, sir.
yeah. So that is a width description in primary ventral hernia. What are the other primary ventral hernia in the abdomen? Other primary ventral hernia as per EHS classification?
Sir, there might be sir, midline hernias and paramedian hernias.
Yes.
And lumbar hernia, sir. So in midline hernias will include sir, epigastric hernia or paraumbilical hernias.
Yeah.
Sir, there might be spigelian hernias.
Yes.
And
Lumbar
and sir,
hernias.
lumbar hernias.
Yeah. So what is the boundary of superior lumbar triangle of petit?
Sir, superior lumbar triangle of petit, sir, it is bounded superiorly by the 12th rib, sir. And sir, sir, the superior triangle is bound by 12th rib superiorly, serratus posterior inferior muscle, and the posterior border of
Right. You are correct. Read. You don't confuse with the other boundaries. There are some muscles which are overlying, but the boundary is lower border of the 12th rib above. Medially?
Yes, sir. Medially, sir, sir, quadratus lumborum and erectus spinae muscles.
Quadratus lumborum is in the posterior abdominal wall deeper. The main muscle is the medial border, lateral border of erectus spinae.
Erectus spinae, sir.
And laterally?
Yes, laterally, sir, sir, posterior border of internal oblique, sir.
Yes. And it is overlapped by two more muscles. Overlapped by latissimus dorsi and the external oblique.
Yes, sir.
Okay, but boundary is the internal oblique.
Yes, sir.
What is the boundary of inferior lumbar triangle of petit?
Sir, inferior triangle is sir, bordered by posterior edge of external oblique muscle anteriorly, and sir, anterior edge of latissimus dorsi posteriorly, and inferiorly, sir, by the iliac crest.
Yeah. So that is the inferior lumbar triangle of petit. Okay. So this patient has got this swelling. What should be your approach for treatment in this patient?
Sir, sir, preoperative workup and surgical management of the hernia should be done, sir.
What is a better way for assessment of the gap in the abdominal wall?
Sir, CCT, whole abdomen focused on the anterior abdominal wall, sir.
So, patient who has got such large hernia, you may not be appreciating the gap, because sometimes the neck may be narrow and patient has got a large hernia.
Yes, sir.
Or it may be a large gap in the abdominal wall, which can classify this as a complex hernia. So in this situation, a CCT scan is desirable to assess the gap in the abdominal wall.
Yes.
Okay. What should be your plan for management of this patient?
Sir, surgical management is to be done, sir,
What
for this
surgery you
patient.
plan?
Sir, sir, making an incision over the hernia sac, reduction of the hernia, and sir,
You'll do,
mesh
your plan
placement.
is to do a open surgery for this patient or laparoscopic?
Sir, laparoscopic surgery may be done, sir. It is less invasive. It might be done while
You defend yourself. You said I'll give incision. You can say that, sir, I'll consider doing open surgery in this patient. Okay. So if you are doing open surgery, what surgery is in your mind in this particular patient?
Sir, mesh repair of the hernia by
Mesh repair.
placement.
Okay. So if you want to put a mesh, how will you create the space, and at what uh, level you like to put the mesh?
Sir, preperitoneal mesh may be placed in this
So
patient,
how
sir.
you create the peritoneal space?
Sir, we will access the space via the hernia opening itself,
Yes.
and
So
we
you
will
have
create
to
an overlap of
so
around 4
so
centimeters.
so by incising the skin subcutaneous tissue, and then by incising the latissimus dorsi and the internal oblique, you will reach the hernial sac. And once you tackle the hernial sac, as you go deeper, you can create a peritoneal space. Okay. So this is a hernia. Is it easy to oppose the gap, or you may have some hurdle?
Sir, if it is a small gap, sir, it might be opposed.
Yes. So
But for
gap more
large
than
gap,
4 centimeter, if the width is more, it is
yes,
difficult
sir.
to close the gap. And if the gap is much larger, you can use some component separation technique.
Yes,
But
sir.
the mesh placement should be done in the preperitoneal space. It's a
Yes,
sable mesh placement.
yes, sir.
Okay. You place the mesh in the preperitoneal level. And if the gap is smaller, you can oppose the gap by interrupted sutures. Okay.
Yes.
If you do laparoscopic repair, what will you follow in laparoscopic repair? Because you see, this is a patient. If you look from the inside, what do you look at? The boundary is rib above,
Yes, sir.
and above this is a retroperitoneal tissue.
Yes, sir.
So, what should be your uh, laparoscopic method for repair of this hernia? What do you do?
Sir, we can go via transperitoneal approach. We can access the retroperitoneal space by incising along the peritoneal attachment of the
There are two.
ascending.
You see, there are two things. One is you said you'll go by transperitoneal approach.
Yes, sir.
If you go by transperitoneal approach, you may remain totally transperitoneal. You need not go to the that is a different technique.
Yes,
If
sir.
you're talking about retroperitoneum, there is a different technique. One is it can be a just a transperitoneal approach, and what you do next? You reduce the hernial contents.
Yes, sir.
You have the gap. If the gap is now smaller gap, less than 4 centimeter, you can place interrupted sutures to oppose the gap.
Yes, sir. Yes, sir.
And then what do you place? If you now want to place a mesh,
Sir, after that, sir, mesh might be mesh
what
may be
mesh?
placed.
What mesh?
Sir,
It
sir,
should be a
composite mesh.
composite mesh because you have gone to transperitoneal. So
Yes,
that is
sir.
one part of transperitoneal repair. What are
Yes,
the other options in laparoscopy? People have come up with new ideas in laparoscopy approach. So what can be the next approach people are doing now?
sir, peritoneal flap may be raised and the mesh may be placed preperitoneal region, sir.
So that is one which is described as transabdominal preperitoneal repair.
Yes, sir.
That is one. What is the next? And more people, AWR people are about this hernia. What is that technique called as?
Sir, totally extraperitoneal approach.
Yes, E-tape. He just cannot go a total X-ray. It's described as E-tape,
Yes, sir.
where you dissect the large area in the extraperitoneal space. Okay, so this can be
Yes.
repaired also by E-tape approach. Okay.
Yes, sir.
Okay. In this femoral hernia, you described a approach for groin incision and then repair. Is it possible to do a laparoscopic approach in patient who has got obstructed hernia?
Sir, in obstructed hernia, sir, usually open approach is preferred.
Yes. So in obstructed or strangulated hernia, usually laparoscopic approach is not advisable.
No, sir.
Okay. So if it is not obstructed hernia or a strangulated hernia, you can approach the femoral hernias by laparoscopy approach. So this is different from a inguinal hernia approach or same as inguinal hernia approach. If you are
Sir,
going by laparoscopic technique, is it different or is it almost same?
sir, it is almost the same because the mesh placement in laparoscopic hernia is in the
Only thing
myopectoneal
is,
orifice.
as you go in, where do you find the hernial sac?
Sir, the hernial sac will be below the sir, just
It will
in
be
front of
behind
the
the.
behind the
In the inguinal hernia, you find either the hernia is direct sac or you find the hernia is indirect sac.
Yes, sir.
Okay. In femoral hernia, you'll find the hernial sac is going behind the inguinal ligament. So that is the only difference. You have to dissect the hernial sac in the femoral canal, reduce it, and then you place a mesh. Once you place the mesh, where do you fix the mesh now? If you want to fix it by tackers, where do you place the mesh and where this mesh should overlap?
Sir, it should be placed over the entire myopectoneal orifice, sir.
Yes.
Sir, around 3 to 4 centimeter lateral to the deep ring. Sir, medially up to the rectus muscles, and sir, inferiorly covering the all the 4 orifices, sir, obturator, femoral, and
So if you
groin
want to fix at all, some people are not fixing, but if you are fixing the mesh, where do you fix the mesh?
Sir, near the anterior superior iliac spine, sir.
That is not the first point. The more important point for fixation is where? Medially, where do you fix?
Sir, cubic.
Coopers. Yes.
Yes, Cooper's
Once you
ligament.
take the lower part of the lower part of the mesh should lie over the Cooper's ligament. So you can put 1 or 2 tackers fixing the mesh to the Cooper's ligament.
Yes, sir.
No tacker should be placed laterally. Okay, near the anterior spine, you should not put a tack because you can injure the lateral cutis of thigh. And then anteriorly, as you go to the anterior abdominal wall, you can place one mesh medially again. Laterally, you can spread out the mesh. Okay. What is the boundary of myopectoneal orifice of Fouchard? What is the boundary?
Sir, the myopectoneal orifice, sir, inferiorly it is bounded by the cubic bone, sir.
Covered by pubic, superior ramus of pubis, covered by a ligament. What is that ligament?
Sir, the Cooper's ligament.
Cooper's ligament.
Yes, sir.
The lower boundary, inferior boundary is superior pubic ramus covered by Cooper's ligament.
Covered by the Cooper's ligament, sir. Superiorly, sir, it is the arch of internal oblique muscle and transversus abdominis. Laterally, sir, iliopsoas muscle. Medially, sir, lateral border of rectus abdominis.
Superiorly is conjoint tendon only.
Yes, sir.
Superior is conjoint tendon, which is formed by transversus internal oblique. Agreed.
Yes, sir.
But it's a conjoint tendon.
Yes, sir.
So inferiorly Cooper's, superiorly conjoint tendon.
Yes, sir.
Laterally?
Laterally, sir, the iliopsoas muscle.
Laterally?
Sir, iliopsoas muscle.
Yes. And medially?
Medially, sir, lateral border of rectus abdominis muscle, sir.
Is it muscle? Make it very clear. Do you find the bear muscle medially?
No, sir, the rectus sheath, sir.
Yes. So, medially lateral border of the rectus sheath.
Yes, sir.
Okay. So, yes, this is a groin region where all the hernia comes up. So idea of this laparoscopic repair is to bridge this orifice and place the mesh, so that I'm asking you that this mesh below and medially should be fixed to the Cooper's ligament, as you described the operation for femoral hernia. Because if you do not cover this marked orifice of Fouchard, you are now not covering the femoral hernial gap.
Yes.
Okay. If you look the abdomen from inside with a laparoscope, what are the important landmarks you see in the groin region? You are looking at the groin from inside the abdomen. What are the important landmarks you see which are helpful for repair of groin hernia? Name the structure from midline to lateral.
Sir, midline to laterally, sir. In the midline, we can see the median umbilical ligament, sir.
You find that
Sir, the median umbilical ligament
formed by
formed by the obliterated urethra, sir.
fine. As you go laterally, find another bulge.
Sir, the medial umbilical ligament, which is uh,
Formed by
sir, the medial umbilical ligament is formed by the obliterated umbilical artery, sir.
yes. As you go more laterally, you find another bulge.
Sir, the lateral umbilical ligament.
Formed by
Sir, the epigastric vessels, sir.
inferior
Epigastric vessels.
So what is the area between the median umbilical ligament and the medial umbilical ligament? What is that area called as? Got my point? There is an area between the median umbilical ligament and the medial umbilical ligament. What is that area called as? That is supravesical fossa.
Supravesical fossa.
This is the area called as supravesical fossa.
Yes, sir.
What is the area between the medial umbilical ligament and the lateral umbilical ligament? This area is site for what hernia?
Sir, indirect hernia, sir.
No, site for the area between the obliterated umbilical artery and the inferior vessel. This is the area for Hasselbalch triangle.
Yes, sir, Hasselbalch triangle.
If you come from the anterior side, this is the Hasselbalch triangle.
Yes,
so this site for
sir, direct inguinal hernia.
direct inguinal hernia. This area is known as medial inguinal fossa.
Yes, sir.
There is an area lateral to the lateral umbilical ligament. That is what?
Sir,
that is known as that is lateral inguinal fossa. That is lateral inguinal fossa.
Yes,
okay,
sir.
so these are the landmarks in laparoscopy you should be knowing, because the examiner might ask you. If you say I'll do laparoscopy repair, the examiner might ask you the landmarks, what you see on entering. Okay. Yes. So if you are doing a transabdominal repair for a groin hernia, you start incising the peritoneum just medial to the anterociliac spine. As you go medially, where this incision should end, as you take the incision in the peritoneum medially, where this incision should end, will you take the incision to the midline or you stop at some point?
Sir,
you are seeing groin hernia repair laparoscopically, you should answer.
Sir, near the epigastric vessel, sir.
No. How can you dissect the direct hernial sac then?
Oh, yes, sir.
This incision should be taken up to the medial umbilical ligament. Clear? Okay. If you go beyond that, what can be the problem? Suppose you are trying to go up to the midline.
To the urinary bladder,
yes.
Sir.
So medial to the medial umbilical ligament, you have the supravesical fossa, where the bladder may lie. So if you keep on taking the incision the midline, you can injure the bladder. Okay, but taking the incision up the medial umbilical ligament, you can go beyond the midline. As you dissect in the retropubic space, is a avascular space, you can take the bladder down and you can dissect beyond the midline. But the peritoneal incision will be stopping at the medial umbilical ligament. Okay, so this is a thing you should always be keeping in mind while doing a laparoscopic repair.
Yes.
Okay, so now you are doing a TAPP repair and you started lifting the peritoneal flap. Okay, However, suppose you have a direct hernia or indirect hernia. So you have to dissect the sac. Now, as you are dissecting the peritoneal flap, you create a space so that you can place a mesh comfortably which does not fold up. What should be your guide to strip the peritoneum towards the upper side? What should be your guideline? You got my point? As you are dissecting the lower flap, this lower flap will be containing the sac in the either direct or indirect hernia. You have dissected the sac. And how far you will now dissect towards the abdomen, towards the retroperitoneum? How far? What is the guide?
Sir, Cooper's ligament.
The Cooper's ligament is much below. As you dissect, Cooper's ligament comes up. But how far you should dissect proximally so that the mesh does not roll up? The point is, as you dissect from the deep ring, you find the structures emerging from the deep ring, the testicular vessels and the vas deferens.
Yes, sir.
So you would keep on dissecting this peritoneum proximally till you find the vas is turning medially. Okay, as the vas turns medially, that is about 5 centimeters from the deep inguinal ring. So that is the point of your dissection. You should clear the peritoneum so that as you take the peritoneal flap flow closer, the mesh does not get curled up. So that is a point for dissection of the peritoneal flap, the point where the vas deferens turns medially to enter into the pelvis. And approximately that is 5 centimeters from the deep inguinal ring.
Okay,
And how far you should dissect medially? You are doing a right-sided hernia. How far you should dissect medially?
sir, in a TAP procedure, sir, medially up to the median umbilical ligament, sir, and in a TAP procedure, sir, we have to cross the midline, sir.
Yes, you have to go at least 2 centimeters beyond the midline. That means
yes, sir.
You are reaching the red to be weak space, and you have to go at least 2 centimeters from the midline.
Yes,
you should overlap the mesh beyond the midline. Clear?
Yes, yes.
You have a complete sac in the indirect hernia. You are now finding that is a complete sac and doing laparoscopy. How will you tackle the sac? You are doing laparoscopic repair, TAPP repair or TP repair, but in this patient he has got a complete sac. It is difficult to deliver the fundus of the sac.
Sir, we will reduce the contents of the sac.
Yes.
And then we can, sir, transfix the sac. And
how will you tackle the sac here now? Is a complete sac. What is being done laparoscopically? You cannot transfix the sac without dissection. What do you do? What you do is you dissect the sac from the cord structures.
Yes.
Okay, you dissect the body of the sac from the cord structures. Make a tunnel around. Okay, you make a tunnel around. Pass a ligature. Ligate the proximal sac. Ligate the proximal end of the sac, and distal sac you just now incise. You now divide the sac. You put a ligature around the sac so that the proximal part of the sac is closed. The distal part of the sac is what? Just incise. You divide the sac and keep the distal end open. You will not place two sutures on either side.
Okay.
Clear?
Yes.
You apply only one suture towards the patient peritoneal side so that the proximal sac is closed and distal sac you are dividing and keeping it open so that the hydrocele doesn't form. That is how you tackle a complete hernia. So it is only 9.6. Okay, will not lengthen further. Thank you, Kamal. So for a case presentation, you keep in mind that you have to give a good summary of the case and then come to a diagnosis by doing a examination of the inguinovalval region. In female, you can say it's a inguinovalval region, not inguinoscrotal. Okay.
Yes.
Any question from any of the students? Any question? If not, we will close. Thank you, Kumar. Very good.
Thank you, sir.
Okay. Thank you, Milind.
Thank you, sir.
Yeah.